All right. Hey everyone, I'm Bree Ropke, and I'm one of the attending physicians through OSU. I'm working with John Lowe here today. Hey John.
Hello everyone.
We're going to just kind of go over some stuff for your COMAT review for OBGYN. Certainly not all inclusive, but we did a bunch of reviews. Hopefully these hit on all of the main points that you'll be needing for your COMAT. Please give us feedback on if we maybe give too much information or not enough in certain areas. We'll be glad to hear from you. Our objectives are just to review OBGYN from, the emergency department perspective. So this is definitely more surface stuff, kind of things that we think about, right, John, when a patient comes in, a female of childbearing age, have you, or, even some gynecological things that we think about.
Right, so kind of a larger surface area view of the OB-GYN perspective for ED, so we'll cover a lot of 30,000 foot approach to it, but there'll be some details in there. So if there's too much or anything, let us know and we'll go back from that, but we'll go ahead and dive in and get started on it now.
So really our approach in the ER, like any female of childbearing age, is we want to know, are you pregnant, right? So a patient comes in, they have back pain, they have abdominal pain. These are all things, even chest pain could be like a ruptured ectopic pregnancy. So if you are a female of childbearing age, one of the first things that we always, think about is this patient pregnant or not? The other things that we do is what we do in any case, right? If they like primary survey, secondary survey, is the patient sick? Are they not sick? And so we're just going to go over some of those. You have anything on that, John?
No, so yeah, the ER approach to female abdominal and GU complaints is pretty much like Dr. Ropke said. Any other emergency department patient, you want to do your initial primary survey and make sure that the patient is sick or not sick, looking at vital signs, but definitely have a lot of complicated problems that can occur in females with abdominal pain, especially in their childbearing years. So it's important to do a thorough physical exam and history so that you can make sure you don't miss a detail that can lead to some catastrophic outcomes.
Right, especially like a lot of patients on infertility drugs, that can kind of change your differential a little. And then as far as, abdominal pain workup goes in women, they can have an appendicitis or cholecystitis, but they can also have a tubo-ovarian abscess or a torsion, and so your differential just gets a little bit broader, and so it's good to have that in the back of your mind when you're looking at these patients.
All right, so we'll have a little present a case here for you. So a 21-year-old female comes into your emergency department complaining of vaginal discharge and dyspareunia for the last week. Doesn't have any significant fever or abdominal pain, no dysuria. She does have normal vital signs and no previous pregnancies. Does report in your history that she has had a new sexual partner. No past medical or surgical history. Denies any alcohol, tobacco, or recreational drug use. Does report that she's on birth control and has no allergies.
All right. Gosh, we have 50 of these chicken of the year a day?
Yeah, pretty much a daily complaint here.
Yeah, and not everyone has a gynecologist that they go to, and so they do treat their ER like a primary, the primary care provider. And really, when you're reading this patient to me, it doesn't sound like they're in a lot of distress. They've got some discharge. We don't have, we don't do pap smears in the ER, and we don't do all of those other procedures, but we do, we check for infections like PID, and so typically, a workup like this is I've decided they're not having a surgical emergency or something, and I want to make sure see if they're pregnant. I want to do a pelvic exam when we do these in the ER.
Right.
Have a chaperone in the room, but really this is kind of more, there's a few things that can cause this, and we'll just go over some.
Yeah. So first, one of the major concerns, we'll just start with kind of the sexually transmitted infections, which is one of the big concerns for any female who comes in complaining of vaginal discharge, especially in females who complain or report a new sexual contact. So we'll start with just chlamydia, reviewing some of that. It's a gram-negative bacterium. It is the most common bacterial sexually transmitted infection in both males and females in the United States. And most common clinical finding in females will be cervicitis. In males, it's urethritis. You'll kind of have these mucopurulent yellow discharge that can have some dysuria. On physical exam, you'll have some cervical edema and erythema. Chlamydia is related to Reiter syndrome, and that's, as you learned in the first 2 years, that's your can't see, can't pee, can't climb a tree, so you get your conjunctivitis, your arthritis, and your urethritis associated with that. Treatment for this from an emergency perspective used to be azithromycin 1 gram as a single dose. That's still in some places considered an acceptable choice, but it has been moving towards doxycycline now. So the Infectious Disease Society of America does recommend using doxycycline.
And that's what we give, right, is the doxy. I think still they're mentioning azithromycin in all the books for review, and I don't know how much testing they'll get on as far as, treatment-wise, but I think doxy's the big one to remember on this. So, and that's in a non-pregnant female.
Yes.
Okay. And then we'll talk about this here in a second, I guess, but basically you do this physical exam and you see this discharge on a female, like we're treating them like they have it. We'll still test them for it, but we treat them while they're in the ER.
So diagnosis of chlamydia and gonorrhea is usually through endocervical or urethral swabbing, but lately with all the COVID stuff that's been going on, it's been more urine PCR testing in our facility. But just know that the true diagnosis of chlamydia and gonorrhea is done through endocervical or urethral swabbing.
All right, and really dispo for these patients, as most of these are going to be discharged home.
Yeah.
And you give them follow-up information. They need to abstain from any intercourse until after completing their treatment and until their symptoms have resolved and their partner's treated. So it's kind of an extensive conversation to have with them. So kind of the same thing that we do with gonorrhea. So gonorrhea is a gram-negative diplococcus. This is something where most of the time not most of the time, but a lot of times these patients can be asymptomatic. You really can't tell when they got it, and then they can just start having symptoms all of a sudden. So it can cause PID, it can cause cervicitis. You're going to get that purulent cervical discharge. You can have dysuria, abnormal vaginal bleeding, and the big treatment here is Rocephin. But yeah, gonorrhea untreated and chlamydia untreated can cause a lot of problems. And we're going to go over a few of the pictures here, but you can get disseminated gonococcal infections through I'm not even going to say the word right, but hematogenous spread here. And these patients can be really sick. So, I've had patients in their 30s come in with bad knee, swollen, you think it's a septic joint, and this gonorrhea should definitely be in your differential for these patients.
So gonorrhea, chlamydia, typically when you see someone with vaginal discharge or symptoms concerning for gonorrhea or chlamydia, you typically will treat for both empirically. It takes a little while to get the cultures back on these, so when you see these patients and they're symptomatic and they have findings concerning for it, typically we'll just cover for both. Gonorrhea and chlamydia like to hold hands and run together, so you will treat with Rocephin and Doxy in most patients who are concerning.
And the reason we treat this is to prevent something like pelvic inflammatory disease.
Right. Pelvic inflammatory disease, typically this is a spread from a lower sexually transmitted infection up into the upper female genital tract. So this is going to be including the uterus. It moves up into the fallopian tubes and other places within the abdomen. It can cause tubo-ovarian abscesses and can lead to infertility and ectopic pregnancies. But some of the findings you'll see on physical exam, you got uterine and cervical motion tenderness. You can have some adnexal tenderness. They'll have that kind of vaginal discharge consistent with a chlamydial or gonorrheal infection. They, most of the time, can present with fever, but it's not textbook. They don't always have to have the fever or abdominal pain and other things. So just know that there are, in clinical practice, atypical presentations, but for testing purposes, they will probably look sick. Yeah. These patients do go on to be at higher risk for ectopic pregnancies and infertility issues, so that's why we want to try to treat this before it becomes a true PID. And like it says on the slide, biggest risk factor there is untreated gonorrhea and chlamydia. Most commonly found in younger females who have multiple sexual partners. also in smokers and those who have IUDs in place. Treatment is again Rocephin and Doxy, and then plus minus metronidazole or clindamycin plus gentamicin if they're allergic to one of those other ones. So in these patients, if you diagnose, again, primarily based on history and physical exam, there's no single diagnostic criteria, but if you are concerned and you lab these patients up and you're going to treat them for PID, you need to consider admitting these patients if they are pregnant, if there's any evidence of a tubo-ovarian abscess, or if they're ill-appearing, or if they have previously failed outpatient antibiotic treatment.
Here's some of those physical exam findings you can see with that disseminated gonorrhea on your hand, that gunmetal gray appearance of those skin changes. And then that's like, you do a cervical exam here, and I see that on exam, I'm going to treat for PID. That versus cervicitis, you see the erythema around the cervix there, and you're leaning more towards cervicitis, but you have all that discharge. And these patients have just a lot of pain on physical examination. We call that like a positive chandelier sign. Yeah. You put the speculum back, and they kind of jump off the table a little bit just because it's uncomfortable.
So one of the complications of PID is this Fitzhugh-Curtis syndrome. These are those fibrous adhesions between the liver capsule and the abdominal wall. Important to note that patients will have normal liver function tests, but this just causes these adhesions that can cause pain and discomfort for the patient. So those violin strings that they talk about in the first couple of years when you went through your obstetrics courses there. But that's just a picture of it there.
All right, trichomonas. Goodness, we see this like every day. Handfuls of times. This is a sexually transmitted infection. So yes. You tell someone they have it, and they're like, oh, did I get it from the toilet seat? No, this is a purely sexually transmitted infection. It's a protozoan. It's like these, I have a picture of that too, which is exciting. But basically, this is something that is associated with preterm birth, PID, cervical cancer, and increased transmission of other sexually transmitted infections. So when we check for other STDs, or STIs, we check for trichomonas, and we treat for that. And the treatment for that is flagyl. Generally, when we give that medication we say, hey, avoid any alcohol if you do drink, because that can cause that. You can get vomiting, diarrhea, abdominal discomfort if you're doing that as well. But on exam, you can see cervicitis. So that's that strawberry cervix. It's red. It looks like speckled, and then you get that frothy green discharge, as you will. And a lot of patients don't know they have it. And sometimes it will be even in an older patient that we have here that it picks up in the urine. So interesting, but we see it a lot. So
diagnosis typically made by wet prep, so cervical swab, and then placed on a wet prep, and then visualized under the microscope. It is important to remember that HIV screening is important in these patients. It is seen up to twice as frequently in female patients with HIV. So anytime you have somebody with sexually transmitted infections diagnosed in the emergency department, you need to consider further evaluation.
Yeah, and a lot of times that means for us that we're encouraging someone to get established with a primary, right, and talk about the importance of following up and getting screened and checked for other things, because we don't necessarily check for hepatitis and HIV and everything, right, because we don't have the means for follow-up and setting up with a treatment plan. So and this is what those little trichomonads look like. So they just are these little oval, pear-shaped with little flagella there. Interesting little guys. That's what that strawberry cervix looks like. You see that speckled appearance. And so I would treat for, honestly, cervicitis. So that can be caused by multiple things, but they would test positive on a wet prep for trichomonas.
Yeah. And typically you'll see this one actually does look like that strawberry. You've got those little punctate red areas on the cervix that actually looks like that true strawberry cervix. That's more characteristic of trichomonas. Typically with like a cervicitis from a gonorrhea, chlamydia, you'll see a much more red and inflamed, kind of friable cervix. So when you touch it, it bleeds real easy with the chlamydial and gonorrheal infections. But you can see this kind of across the spectrum.
All right.
So genital herpes, always a fun topic. This is most commonly caused by the herpes simplex virus 2. It does cause these painful lesions that start with kind of small clumps of blisters that proceed to almost like vesicular appearing lesions. May have proceeded in the area with some like localized pain, itching, burning sensation that right before these vesicles popped up. Don't always have to have any like systemic or constitutional symptoms with them. Sometimes it's just the pain and ulcerative lesions in the genital region. It is the most common cause of genital ulcers in the United States. Important to note that typically HSV1 causes those oral lesions. HSV2 primarily causes the genital ulcers, but they can kind of go back and forth. It is a chronic illness. There is no cure, but it does have acute exacerbations. Once, like it says, it can remain dormant and reactivate periodically during times of stress or immune compromise or other times. Asymptomatic subclinical viral shedding can occur even after the primary infection resolves, so they can still be spreading this infection even when they don't have an acute outbreak, but it is more likely to spread during acute outbreaks. Diagnosis is, again, basically clinical. Painful grouped vesicles or ulcerated lesions on the vagina, the prelabia, or the labia. You can send a viral culture. Better option is usually this HSV PCR for diagnosis. Pregnant women who have an active genital herpes outbreak do require C-section rather than vaginal delivery. Typically, we treat this with one of the antivirals like acyclovir, valacyclovir, or famciclovir. That just is kind of decided based on patient availability. Famciclovir is much more expensive than acyclovir is. It's a little bit easier dosing-wise, but we kind of have that conversation with the patient and what's going to be best for them.
All right, and that's kind of what some of that can look like before they kind of blister up. You'll see that top lesion there. It's already kind of ulcerated and kind of scabbed over, but they're painful. They come in. A lot of them will be aware that they have this infection and be just requesting the treatment, and others, it's kind of just a unfortunate diagnosis that they walk away with that it's disappointing for the patients, and really you need to take the time to talk to them about everything that, just that this is something that you'll have forever, and, how to avoid passing it along, etc. Now, Condyloma acuminata. Every time I say this word, I think of the Lion King, and anyhow, these are anogenital warts. This is the most common viral sexually transmitted infection in the U.S. So HPV. We actually have Gardasil. We have some vaccines against some of the more common types that can cause cancer, type 6 and 11. Is that right? Is that what Gardasil, or is that just the HPV, the 6 and 11 most common?
That's the most common.
Yeah.
I think Gardasil does protect against 6, 11, and 2 or 3 others of the HPV viruses.
Yeah, so really treatment for these, Imiquad, cryotherapy. Some people opt to not, mess with them, but certainly can. That's not something we're going to do from the ER. Where this is kind of more, we can diagnose or say, I think this is what you have, you need to follow up, is really essentially from our point of view. And then these patients are at increased risk of anogenital cancers. And that's kind of the look of that. And some of these can overlap. It can be hard to distinguish one from the other. And we just are open and honest with our patients, like, hey, I'm concerned this is what this is. I couldn't say for certain this is, you need to follow up and get this evaluated.
Right. Oh, syphilis. So syphilis caused by this spirochete, the Treponema pallidum. Most cases are sexually acquired. Sometimes, though, it can be passed via direct contact with an infectious lesion, either during intercourse or even sometimes through non-sexual intercourse when it's spread from primary to secondary syphilis. Primary diagnosis of primary syphilis is that painless chancre either on the penis or the labia, somewhere in the genital region. You'll have that diagnosis of that painless chancre. If it's untreated, it'll move on to secondary syphilis, which then starts having this condyloma lata, not to be confused with the Condyloma acuminata. That is with the HPV. It's these genital warts and bumps that come up that are associated with syphilis. You also can have patches on the mucous membranes, or even you get kind of this disseminated secondary rash on the skin, lesions that are kind of macular papular. They can be kind of a pale red or pinkish color, typically involving the palms and soles of the feet. Diagnostic testing is done. It's serologic testing. They've got the multiple different forms of that. You've got the...
I think every facility is different, right? So I don't know that for testing-wise, it's just a serological test.
Okay. It progresses on to, if it's untreated, we do treat with penicillin G. It's an IM shot, a couple million units, usually into a large muscle group. If it's untreated, it can progress into late syphilis or tertiary syphilis. This is where you start getting into either a latent disease, or they develop into some type of neurologic infection. That's where you get tabes dorsalis, you get the infection of the spinal columns, you get infection, you can get neurosyphilis, you can get ocular syphilis, then it just kind of spreads into more complicated infections that require a long time to treat them with different antibiotics. And it is something to be aware of, but it's not super common that we see tertiary syphilis. Syphilis is increasing in the United States again. We're seeing many more co-infections with other STIs with syphilis now, so it is important to keep on your differential and test for and treat.
Certainly, have seen too many cases of this, and it's something, like you said, we look for findings and we're suspicious and we treat for it and we test for it. But goodness, it's everywhere, and it's definitely, unfortunately, something that has a lot of bad outcomes if it's left untreated. So, and here's some findings. So, you've got a lot. This is after the primary, that chancre, which a lot of people don't come and get treated because it's not painful. So this is weird. They'll attribute it to a lot of different things, but they won't attribute it to an infection, which is, it's strange. But, once something starts becoming painful or uncomfortable, that's when they're like, wait a minute, this is weird. And I distinctly remember that rash on the hand being a part of a test question. So I would say, rash on palms and soles can only be a few things, and this is one of them. It can cause lesions on the lips. That's that condyloma lata in the middle there, and then it can also cause lesions in the mouth. So,
yeah.
All right.
Knowing that rash on the palms is very common.
Yeah. Oops. Sorry. Going to pause for just a second.
Oh boy.
All right, now we have bacterial vaginosis. This is also, it's just like a watery discharge that patients complain about, or the big one I think on the test is this whole foul, fishy odor business, and they'll still say the whiff test, which we don't do in the ER. But really, this is not a sexually transmitted infection. It's one of the ones that you're like, hey, this isn't sexually transmitted. This can just happen when your pH gets off balance. The treatment is the same as it would be for trichomonas. It's flagyl. This is like a Gardnerella vaginalis, it might be in the test question, and then as well as clue cells, and we'll show you what that looks like. But it's these epithelial cells that are coated with bacteria. And I don't know if this is important, but the pH of bacterial vaginosis is greater than 4.5.
I've seen that be a differentiating on test questions between bacterial vaginosis versus a Candida yeast infection. So just kind of important to know that the pH difference, and then your flagyl will be your treatment for that. The little picture of those clue cells there, what that kind of looks like on wet prep. You can see the epithelial cells, and they're all studded there with the coccobacilli all around them there. So.
All right, and then this is that Candida vulvovaginitis, and so this is more from a yeast infection, right, is the thing that you commonly hear, I guess. Right. So patients will come in, they have that discomfort, they'll complain of pruritus or painful intercourse, and then they have this kind of cottage cheese discharge. Yeah. And this is the most common cause of vaginitis. It is also not a sexually transmitted infection. The pH is around 3.8 to 4.5, so under 4.5. And then really the risk factors for these. So I think this is something where, we're not this isn't an emergency for us, but if you see people with recurring infections, you need to maybe think, does this patient a diabetic? Is one of the things I would take it a step further. If someone's like, I get these all the time, maybe do a finger stick. Otherwise, patients that are pregnant can get these more often, or we have a lot of patients that are, hey, can I also have diflucan if you treat them for a urinary tract infection, because they tend to get a yeast infection after taking antibiotics. And really the treatment's oral fluconazole if they're not pregnant, or topical azoles if they are. And this is what that looks like. It's that budding spores with pseudohyphae on a wet mount.
So another common thing we see in the emergency department would be these Bartholin cysts or abscess. These form out of the Bartholin glands. They're located at, if you think of clock face, they're located at the 4 and 8 o'clock positions on either side of the vaginal orifice. Typically result because of some type of blockage of the Bartholin ducts that leads to this kind of polymicrobial infection. In the emergency department, treatment is typically incision and drainage, followed by sometimes we'll put these patients on antibiotics. Not usually are they necessary once you get a good incision and drainage. They do have this in the books and the documentation on it. It'll say put this word catheter in place. Not something we typically will do in the emergency department anymore. Usually good incision and drainage is what will work clinically, but on test questions I think they still will discuss the placement of this ward catheter. Following up the patient with obstetrics and gynecology is important, because sometimes these will require what they call marsupialization, which is a procedure done by the OB doctors. So.
And they don't typically present to us unless they become an abscess. Otherwise, It's just kind of this pressure discomfort. But then when they get to us, it's kind of this. It's incredibly painful. They can't sit. They can't walk.
Right.
And I was actually surprised, but this is more of a polymicrobial infection. And I was thinking, this is gonorrhea and chlamydia. It's just that duct gets blocked, which causes that, cyst, and then those can get infected. So... All right, this is just kind of this is what that word catheter placement looks like, or really just how you approach incision and drainage. And we do a lot of these actually, but I've never placed a word catheter. It's just more kind of, hey, this is follow-up information. But that's kind of how you approach the IND to this.
Dysfunctional uterine bleeding. This is heavy vaginal bleeding in the absence of some type of structural or organic disease, which sounds pretty vague, but that just means that they're having uterine bleeding that doesn't fit with their menstrual cycle, or some type of spontaneous abortion or fibroid or some type of structural disease of the uterus. And these can get pretty serious. They can be anywhere from mild disease, where the patient just needs maybe some supplemental iron in their daily intake, to patients trying to have bleed out and die on you. We actually have seen a few of those in the ER over the past few months, of people who have just significant dysfunctional uterine bleeding, who are severely anemic, requiring blood transfusions. So it's just something to be aware of. History and physical exam on these are going to be the biggest thing. You want to ask them how long they've been bleeding for, how many tampons or pads are they going through an hour. Do they have any of the higher risk factors? Are they pregnant? Do they have any significant historical findings that way? Looking at their vital signs, just the typical emergency medicine primary survey.
It's really our job, because a lot of people come in for vaginal bleeding, and so from there it's just our job to determine, is this an emergency? Are you bleeding so much that we need a transfusion, or someone needs to intervene, or is this an ectopic pregnancy, or et cetera. But gosh, we've had people with hemoglobin of 3 and 4 and 2, and you're just like, oh my goodness, how long have you been bleeding like this for? So these are, that's kind of how we approach it. And then typically, I'm not starting an iron supplement in the ER. I'm just more, hey, follow up information.
Yeah.
So
typically, it's good to get these patients followed up with obstetrics so they can get managed appropriately.
So now you have a 31-year-old female that comes in, lower abdominal pain for a day, crampy, intermittent, non-radiating. Nothing seems to make it worse. It's somewhat better with ibuprofen. They deny any dysuria. They're not nauseous, no vomiting, no diarrhea or constipation. Vitals significant for a heart rate of 115. And they don't have any medical problems, no surgeries. They don't smoke, drink, or do drugs, and they take occasional ibuprofen. So, I mean, this person, gosh, I think all of these is just to point out that this is kind of our daily presentation in the ER, and like we do with any female, it's, hey, is she pregnant? Is she not?
Right.
So
it's important, as you can see in that history on that case presentation. Important question. She's a young female with lower abdominal pain, so there's more history that you would want to know there. Has she had any vaginal bleeding or discharge? Anything along those lines that could lead you down to one of the obstetrical emergencies or things like that. So making sure you take that good history is important.
And kind of like we do our oral boards here, it's like patients are pregnant until proven otherwise, right? So that one, and then just that whole pelvic infectious disease that we just,
EMS room 10.
sorry about that we just kind of went over to is all inclusive there. So, all right. All right, back. Now we've got endometriosis. So this is when there are endometrial glands at extrauterine sites. Most common is your ovary. This is associated with chronic pelvic pain and infertility. And the diagnosis is actually by direct visualization, which is through a laparoscopy. Really, a lot of patients that come in, you'll know they have it because they tell you they have it. They've been diagnosed because they've had a lap, and it's kind of a exacerbation of their pain. And really, we'll treat their pain, but we just have to rule out, make sure they're not having, any of the other things that can cause abdominal pain, and that they're not just anchoring to that.
Yeah,
so.
Not a diagnosis made in the ER by any means, but
Right.
we treat it quite frequently.
Right.
So uterine fibroids or leiomyomas. This is the most common pelvic tumor in women. They do contain these estrogen-sensitive receptors, so they can get rapidly larger during pregnancy, but will tend to get smaller during menopause. Typically present with some type of pelvic pain. They can't have this abnormal vaginal bleeding. Treatment is usually not initiated in the emergency department. Sometimes this diagnosis can be made when we get a transvaginal ultrasound or something in the emergency department for other reasons. Looking for ectopic pregnancies or other things that are concerning there, and then we'll find a incidental finding of a fibroid there, and we'll just kind of let the patient know, hey, you need to follow up with obstetrics for this. The OB-GYN doctors who will use hormones sometimes. Eventually, sometimes they can go in and take parts of the fibroid out, but definitive treatment is hysterectomy.
All right, Mittelschmerz. That's just that mid-cycle pain. This is typically 2 weeks after the start of the last menstrual period. This is common in women with regular periods that aren't on birth control, and pain is a result of ovulation itself, and it can lateralize to an ovary. And these are more just kind of quick fire. You might see this as a test question, but nothing that really is anyway related in the emergency department. So no emergencies.
So primary dysmenorrhea, this is that cramping lower abdominal pain that occurs just before or during menstruation in the absence of other pathology, so such as endometriosis or something else. Again, this is going to be one of those rule-out diagnoses that we make in the emergency department. So if somebody comes in, a young female with crampy lower abdominal pain, we're going to do our primary survey, and we're going to look for the big, bad, scary things, ectopic pregnancies, other stuff. Once we've ruled all those out, then they will go follow up with an OB doctor for this diagnosis. Typically starts when they're adolescents. They'll have a fairly benign, normal physical exam and typically improve with NSAIDs.
So ovarian cysts. Most common ovarian cysts are functional or follicular cysts. The less common causes include your PCOS, cystadenomas, and dermoid cysts. They are generally greater than 1 centimeter in size. They are at risk of torsion when they're more than 4 centimeters. If they're less than 2, they're virtually risk-free from torsion. Most cysts tend to be asymptomatic. They can cause dull pelvic pain or fullness. They can be significantly painful if they're ruptured. They can cause painful intercourse and pressure on the bladder. If there's bleeding into the cyst and it ruptures, that can actually be life-threatening with signs of peritonitis and shock. So we would do a bedside ultrasound and you'd see abdominal free fluid. It would be a positive fast examination. So the goal for us is really to determine if this is a ovarian mass. Is it an ectopic pregnancy? Is it a tubo-ovarian abscess? Is it large enough that it could cause a torsion? Is it causing a torsion?
Yes.
Or is this a sometimes they can kind of twist and untwist, and so if it's large enough, I'm generally calling our OB/GYN to come and evaluate the patient. And these patients are also getting like a pelvic examination. You're feeling for adnexal fullness, etc. And once you exclude all these scary things, you're really just referring them, like we do with all the rest of these patients, to follow up with OB/GYN, and you can give them NSAIDs for pain.
And that leads us kind of into torsion here. Torsion is actually kind of an extension of the last topic there. It refers to the complete or partial rotation of the ovary on its ligamentous support that can result in ischemia. This is one of the most common gynecological emergencies. Sometimes the fallopian tube will often twist along with the ovary as well. This is referred to then as an adnexal torsion. These usually require some sort of urgent surgical intervention to avoid loss of function of the ovary or the fallopian tube itself. It is common in reproductive age adults. The risk factors for these, again, are those ovarian masses or cysts. Fertility treatments, this actually significantly increases your risk of ovarian torsion, and with the growth of infertility treatment centers and IVF, it is at higher risk now than previously. So cysts greater than 4 centimeters and ovarian neoplasms account for about 94% of all cases in adults. They're more common on the right because the sigmoid colon tends to help stabilize that left side, but they can be on either side. Clinically, these patients will present with a sudden onset of sharp pain in the lower abdomen. Majority of them will also have nausea with vomiting. Diagnosis is usually done by ultrasound. Will show diminished or absent blood flow in the ovarian vessels. At that point, it's important to know that the ovary has dual blood supply, so you'll actually you may not see a complete absence of blood flow. Many of them will have some normal blood flow to the ovary itself. 2/3 actually will have an ultrasound with normal blood flow. However, the venous and lymphatic obstruction occurs long before the arterial disruption gets complete. So you'll actually see an enlarged ovarian volume, which is more indicative that this may be a torsing and sometimes torsing and detorsing ovary. So if you see that and you have the right clinical picture, even if you have a normal ultrasound or a non-specific ultrasound, it does warrant a consultation with the OB/GYN doctors.
Yep. And this is, like you said, management is surgical intervention. And so if you're worried about it enough to do the ultrasound, you're typically calling the OB to come down and take a look at him. And this is that whirlpool sign on that transvaginal ultrasound. It has that on the left, it's the grayscale, and on the right, this is when you have Doppler, and that just shows the swirling of the ovarian vascular pedicle. So you might see this. I know they're starting to show more ultrasounds on tests. So. And then, that another thing, a tubo-ovarian abscess. Most of these are actually polymicrobial. In the treatment for these is antibiotics, but sometimes they actually require surgery. And so when they're large enough, or they're not getting better with antibiotics, they do tend to be taken for incision and drainage. This can also be that result of that ascending infection from an STI that's been untreated. And And really, that rupture of that abscess, which that would be terrible. It could result in sepsis. And then clinically, these patients present with painful intercourse complaints or vaginal discharge, disproportionate unilateral adnexal tenderness, or they have that adnexal mass or fullness on exam. They may or may not have a fever as well. So let's see here. Up to date, that's the treatment is Rocephin, Doxy, and Flagyl. And
just here, a little ultrasound imaging there. You'll see that complex fluid-filled tubular structure next to the fallopian tube there. You can kind of see it, just the positive arrow sign pointing to that tubo-ovarian abscess. So miscarriage, this is unfortunately something that we see frequently in the emergency department. It can be both an emotionally difficult and a physically intense diagnosis for the patients. I mean, sometimes they come in with significant bleeding that can be life-threatening. Other times it's just the fact that you're diagnosing them with a miscarriage that can be emotionally difficult for the patient. So it's something to keep in mind how you approach these patients from a humanistic point. But there's different types that we take care of in the emergency department. So these are terms that you will see on testing that are important to know. So your threatened miscarriage is going to be vaginal bleeding in the presence of an intrauterine pregnancy. They may have abdominal pain or one or the other. But on physical exam, you'll see a closed cervical os with an intrauterine pregnancy. So that then makes it a threatened miscarriage. This inevitable miscarriage is one that they have bleeding and pain and cramping with an dilated cervical os. And once the os starts opening, that makes that an inevitable miscarriage. And then the incomplete is where they've had bleeding and pain, cramping. They may have passed some large blood clots or products of conception, and the os is open.
The other terminology you may see in your test is a threatened abortion or inevitable abortion or incomplete abortion, right, which is actually more likely to be the terms used, I think. So
yeah.
Sorry. So that miscarriage, when you have the complete miscarriage is another. That cervical os is actually usually closed, and your ultrasound will show an empty uterus. And then septic would be when you have this polymicrobial infection when bacteria enters the uterus. These patients will have fever, abdominal pain, vaginal bleeding, and some discharge as well. But you'll have to give them antibiotics and call OB to come and do a DNC. All right, this is a big one for us, the ectopic pregnancy. So approximately 50% of women with ectopic pregnancies have no risk factors. The number one risk factor is a previous history of ectopic pregnancy. Heterotopic pregnancies, incredibly rare. I've never seen one. I've heard of someone that has seen one, if that counts. But, just because you see an IUP and they're having severe adnexal pain, you can't necessarily say that it's not a heterotopic pregnancy. And I would really think that this would matter the most is like if you're on fertility drugs, it would be something where I would say, hey, this patient's in pain. I see an IUP, but they are on this medication, and I would call an OB just to have them come and evaluate them as well. And so that's just talking that visualizing the IUP does not rule out the concomitant ectopic pregnancy. The most common location for ectopic pregnancy is the fallopian tube. When we see these patients, it's really, they come in with pain. We get a bedside ultrasound. We do those ourselves. If we don't see an intrauterine pregnancy, we do a urine preg. If it's positive, that kind of opts us to, hey, we're going to add a hormone level, that HCG measurement. And then there's this number that we're looking for to say, hey, we should be seeing something at this point or we shouldn't. But if they're having pain, ectopic pregnancies don't follow the rules. Right. So, if it's a high hormone level, it's like, hey, it's 1900, 2000, we should be seeing something on a transvaginal ultrasound, and we don't. That's going to be an alarm for me to call OB. Let's see here. And then sometimes they're just, hey, this level's low, they're having pain. We're going to have them follow up in 24 hours for a repeat hormone level. Another thing on these is you want to make sure, is the patient having vaginal bleeding or not? Because we want to know their RH. If they're O positive, no big deal. But if they're an RH negative, we're going to need to give them RhoGAM as well if they're having some bleeding or if they had some kind of abdominal trauma. Yep. This is showing that ruptured ectopic pregnancy. So Dr. Lowe works with me. We all hear, to view or is no view. So if I do a bedside ultrasound and I see that, I'm like, hey, I see an intrauterine pregnancy. That's not the uterus. But, no. In some view, it might look like it. And right. That's why we do the transverse and longitudinal views to identify everything we need to say. Because, that may look like it's in the uterus, but it's certainly not. In those areas where it's darker, there is actually free fluid in the pelvis. Mm-hmm. And so that is a ruptured ectopic pregnancy. This is very sick patients. These are surgical things really fast, right? So.
Yep. So like Dr. Ropke just said, ectopic pregnancy treatment definitively is going to be some type of either surgical or non-surgical management. Ruptured ectopic is almost always going to be laparoscopy for definitive management. But if you catch an early one where they're not ruptured yet, there is some non-surgical managements that OB will typically try to do. They have to be in the right patient selection. So typically hemodynamically stable patients with low quantitative HCGs and an ectopic size less than 4 centimeters with no fetal cardiac activity. So it's a very specific set of group that can be treated with methotrexate. Basically, the most common side effect of treatment with methotrexate is this separation pain that represents that tube distension. The patient needs to be treated and monitored until they can say that the HCG goes to 0 and they don't have any further evidence of that ectopic. Mm-hmm. One of the times you got to be concerned is sometimes these patients will be treated with methotrexate and then they come back with significant pain. You got to rule out ruptured ectopic. It's right. Not that they've already been treated for ectopic. You still have to prove that it's not ruptured at that point. Mm-hmm. And that moves on to the definitive treatment.
Yeah. And just a couple of points for you. The most common cause of maternal death in first trimester is a ruptured ectopic pregnancy. The most common cause of maternal death overall is actually a pulmonary embolism, and the risk of thromboembolism is highest in your postpartum period, interestingly enough. So RhoGAM, that's kind of that thing we talked about just for briefly. This is indicated in pregnant bleeding patients who are Rh negative. There's no need for RhoGAM if mother and father are both Rh negative. But really on our end, we're doing the blood work. If it's a trauma, they're getting it. If they're Rh negative, if they're having bleeding, and we're giving it. If they're less than 12 weeks, you can give the 50 micrograms. And if they're greater than 12, you give the 300, the full dose.
And that's important. The RhoGAM is important, like you guys know, for that alloimmunization stuff. You don't want mother to have antibodies against a potential further pregnancy. So it is a very important thing that we do because it can cause spontaneous abortions in later pregnancies if you're not conscious of making sure that you give these. So.
Leading into obstetrics, in the emergency department, kind of one of the cool things we get to do is we see all kinds of patients, and if they are pregnant, we typically don't have to see them, but if they are under 20 weeks, or if you're out in an ED where OB is not available, we're going to see these patients. So these physiologic changes in pregnancy are important to know. You have an increased heart rate, increased cardiac output. They can have an increased white blood count, which doesn't necessarily mean anything bad, right? It's supposed to happen, and an increased tidal volume. There's no change in their respiratory rate, so these patients could have some subjective dyspnea, which is difficult because they're also at increased risk for clotting. So they're coming in short of breath because they're super pregnant. Right. They have no room to breathe, but then you're like, do they have a blood clot or not? So these can be tricky patients to evaluate, and they can get sick. In the second trimester, they can have they'll have decreased blood pressure, BUN creatinine ratio, and delayed motility. So they get constipated, and it's uncomfortable. We do a lot of the things, and our job is really just to make sure that they're not having a complication in pregnancy. So we look at vitals like elevated blood pressure, That's a red flag we look at preeclampsia and all of that. And then we're all fairly good at ultrasounds as well. So
So typically ultrasound in pregnancy will do, and again, from an emergency perspective, we're looking to rule out the bad emergencies in obstetrics. So we're making sure that are we seeing an intrauterine pregnancy? Are we seeing pelvic free fluid? We're ruling out ectopic. We're ruling out the scary stuff. Earliest ultrasound findings of pregnancy, typically you'll see a gestational sac somewhere between 4 to 5 weeks. By transvaginal, by 6 weeks, you should be able to start seeing it transabdominally. The first true embryonic structure you'll see is that yolk sac, typically seen somewhere between 5 and 6 weeks on ultrasound. So this is just a sequence of events you can see in early pregnancy. So you'll see that small intrauterine fluid collection somewhere 4 to 5 weeks. Then somewhere 5 to 6 weeks, you'll start seeing that yolk sac. That's an unequivocal sign of pregnancy there. That means that there is a pregnancy moving forward. 6 weeks, you'll start to see the embryo attached to the yolk sac, and then somewhere around 8 weeks or so, you'll start seeing the actual amnion, and it'll start to appear to be more like a fetus.
So. That discriminatory zone, you'll see that from 1500 to 2000 quantitative HCG, so that hormone level. You should definitely see something on a transvaginal ultrasound. Right. And then from 4500 to 5, you should be seeing that transabdominally. And like we said earlier, you can have numbers lower than this and they could still have an ectopic pregnancy. So right. Clinically, use your judgment there. If they have, 160 and they have this large adnexal mass or severe pain and they're pregnant, ectopic pregnancies don't follow the rules. Right. But that's when you should definitely be seeing those findings on exam. And that's more what our bedside ultrasound looks like, right? We do that. That's showing some measurements, but I'm looking for that double decidual line. So you see that gray, like that kind of circle in the uterus. And then you see, and that's on the far left. And you can see that little, the pregnancy actually in there as well. But when I see the yolk sac and that double decidual line or sign, or I see like the IUP there, we can say that's an IUP and we see it in two views. Mm-hmm. And then that's the M mode that they're measuring, like a fetal heart tone there. And once you rotate with us, you'll get countless experiences of bedside ultrasound and doing these. So
one of the obstetrical things we see quite a bit of is this actual hyperemesis gravidarum. So nausea and vomiting is pretty common in pregnancy, especially during the first trimester as a result of elevating HCG levels and things. But hyperemesis is that point where it becomes intractable nausea and vomiting. There's no strict diagnostic criteria, but it is generally just defined there as that intractable nausea and vomiting with some degree of weight loss. Usually you start with a UA, you're looking for ketones in that. When we see these patients, we usually don't wait for the UA. They're obviously they look like they're uncomfortable, they're vomiting a lot, they're not able to hold down fluids. So we give them IV fluids. Typically we'll give them some sort of dextrose containing fluid, so D5 normal saline or D5 lactated ringers. Something to give them back some volume and some sugar, help shut down that ketone production. Usually we'll then treat them with antiemetics. We want to make sure we're using ones that are safe in pregnancy, so we use a lot of Reglan and Benadryl to help with some of the dystonic side effects of the Reglan, but that's pretty good for treating these patients. Usually we have good resolution of that, and they can typically go home. Right. If they don't respond well to that and they're requiring quite a bit or they're severely ill, then they require observation.
Yeah. In the hospital with the OB.
So.
Yeah. Human chorionic gonadotropin, so that HCG level that can be detected as early as 6 to 12 days after ovulation, and it doubles every 2 to 3 days for the first 10 weeks. Declines every 2 to 3 days for the next 10, and it's detectable, and this is important for us, is, after 2 to 3 weeks after delivery, you can still have that positive level, so it doesn't necessarily mean they got pregnant again. Twin pregnancies, on average, have that higher HCG level than in singleton ones, but they still fall within normal range for singleton pregnancies.
Gestational trophoblastic disease, molar pregnancies. These risk factors include extremes of age, so young pregnant females or older pregnant females, so less than 20, greater than 35, or a history of previous gestational trophoblastic disease. So these patients, you'll see serum HCGs that are much higher than normal IUP levels, and you'll usually have a uterine size that is much greater than the stated gestational age. This can be associated with that hyperemesis gravidarum. So if you see somebody who just has persistent nausea, vomiting at extreme levels, want to make sure that you're monitoring them for this. There are benign gestational trophoblastic diseases. These are non-cancerous tumors that develop in the uterus, usually due to some sort of extra set of paternal chromosomes in a fertilized egg. That leads to either the partial or complete mole. So a partial mole, this is probably important for testing. A partial mole does contain fetus and cardiac activity. Complete mole has no embryo or normal placental tissues, so that's just a good differentiation to know for testing purposes. Your HCG should be monitored after your treatment of this to assess for persistent disease, and they need to for sure follow these levels to 0. So if you throw a bedside ultrasound on and you are concerned that they may have gestational trophoblastic disease due to elevated HCGs, an abnormal bedside ultrasound, and concerning findings, this is going to be consultation with OBGYN.
Yeah. And this is that snowstorm appearance that you see on ultrasound. You see those little vesicle-looking things, and they're only a couple weeks pregnant. That's concerning for this. And usually we get an official ultrasound, and then we call upstairs. And the malignant ones, it's an invasive mole, which can cause that choriocarcinoma. That's why we worry about, following these levels to 0. And that's not necessarily with us, but we want to make sure they have someone, because the treatment of that is chemotherapy, because these are invasive and malignant. So this is just extra random stuff. I don't know if it's going to be on test necessarily. This would be, I can't tell you anything magical to memorize this, but I would say the big ones are warfarin, ACE inhibitors, and NSAIDs there. And then you'll know, or you'll learn, is a lot of antibiotics are contraindicated as well. So I guess if you're in, we diagnose a lot of, pregnancies, and it's just kind of, hey, this is someone with a lot of medical problems, they have seizures or whatever. We review their medication list and just discuss the importance of, some of these medications, may be bad for your pregnancy, and so you need to call your OBGYN and kind of go over things, as well as your primary. You got to team up with them. Yeah. And luckily for us, we have a pharmacist in the ER, so that kind of helps us a lot. But a lot of these are definitely unsafe in pregnancy, and so they have to be switched up for their treatment of their chronic issues. This might be a test for sure, though.
Yeah,
question.
I was gonna say, vaccines in pregnancy is ones that are for sure, I think, fairly commonly tested. I've seen a couple on our board exam reviews. So safe vaccines: tetanus, influenza, hepatitis B, rabies. Big one to know would be the unsafe one is the MMR. It does have high teratogenic risk, especially during organogenesis, so the early pregnancies. So just making sure that you're aware of that.
Yeah. And that's really for anything, is that highest teratogenic risk is during that period, the 4 to 12 weeks. So when they're taking any medications, or if they're, we say, hey, don't smoke marijuana or drink alcohol, right? Kind of frowned upon, but definitely something that they need to be aware of, because they don't think about that. Or even ibuprofen's a big one for later in pregnancy. The other thing too, and I didn't mention, is the COVID vaccine. That's so new. I don't think you're going to be tested on it. But they're definitely recommending that right now. I think they're the OBGYN, their colleges. So
I was going to say, right now, I think they're saying it's fairly safe in pregnancy.
Right.
All right, so another case. You have a 22-year-old female, 32 weeks pregnant, G1P0, presenting via EMS after an MVC. She was the restrained driver in a rollover, complaining of abdominal pain on arrival. Becomes pulseless shortly after being transferred to the ED bed, and you have an unknown medical history. So this is kind of every ER physician's nightmare.
Yes.
So we'll talk a little bit about trauma in pregnancy here.
Right. So initial trauma case is the same as our non-pregnant patients. So we are but when we have this patient that has a gravid uterus above the umbilicus, and we're like, shoot, this is somebody that has maybe we can potentially save the baby. The goal is really to, if you're treating mom, so you're saving mom, you're also saving baby, right? We're going to turn these patients on to the left. So I think that's going to be a question potentially. Yeah. So you're manually displacing the uterus. You're relieving the pressure on the IBC so they can get that return blood flow.
Right. And
you're avoiding hypotension there. Another thing to note in trauma and pregnancies, your chest tube should be inserted 1 to 2 intercostal spaces higher than normal. all trauma patients that are greater than or equal to 23 weeks need at least 4 hours of fetal monitoring if this isn't like someone that's dying, right? So if they're like, they hit their belly, we clear them in the ER, we rule out some emergencies, and we put them upstairs for tokometry.
Yep.
There should be no radiologic tests that should be withheld if it's needed for maternal evaluation.
Right.
Or their stabilization, because maternal stabilization is your most important factor. You save mom, you save baby. And you want to consider ROGAM if there is abdominal trauma. And another random is the first step of ACLS care of pregnant women is to displace that uterus. And then you're going to start compressions.
Yeah, and that's a big factor in trauma in pregnancy is that displacement of the uterus. If you think about all that pressure coming down on the IVC, they're losing that return of blood flow to the heart, so they lose all their preload. So that's big to know.
Yeah. And so that we had that case that, they lost pulses. What's my time frame on this? And I don't know that this is a test question for you, but it certainly was ours in ER.
Yeah, so typically for us in the emergency department, if a pregnant female with a gestational age greater than 23 to 24 weeks, the first step is to displace the uterus, and then we got to consider doing what used to be called a perimortem C-section, but now is known as a resuscitative hysterotomy. And our time frame is really that needs to be ongoing and done within 4 minutes of cardiac arrest.
Yeah. So once the mom hasn't returned, we didn't get ROSC in 4 minutes, we're going to actually perform a perimortem C-section. And hopefully you have an OB around that you call and a pediatric, because now, quickly you'll have 2 patients that you're going to be resuscitating. And another thing to note is how we're guessing that age is because nobody's going to come in with a sign saying I'm 23 weeks pregnant. Sure. You do that by like measuring the height above the height of the fundus. So once it reaches the umbilicus, that's approximately 20 weeks.
Yep. And
it increases, 1 centimeter for each week. And so just under this like xiphoid, they're about full term there. So, but really 3 centimeters above that, you're thinking this could be a viable pregnancy.
Yep.
And this is just showing displacing that uterus to the left. Left is the big one, right?
Yep.
Not right, but correct. Okay, here's a random question for you. What is the most common surgical emergency of pregnancy? Do you know?
So, ironically, the most common surgical emergency of pregnancy is actually still appendicitis.
Okay, so but if they're really pregnant, these can actually appear like right upper quadrant pain, right? Because it's just like pushing the appendix up. So that should be something that you should think about. We're just throwing random knowledge bombs at you.
So premature rupture of membranes. So this is that rupture of the amniotic sac prior to the onset of labor. This is associated with frequent digital pelvic exams. If there is concern for the premature rupture of membranes, you should have do a sterile speculum exam first just to see if there's any fluid in the vaginal vault. There's these testing that can be done. So there's ferning. That's where they take a little swab of the amniotic fluid and they put it on a slide and allow it to air dry. That is the most specific test for premature rupture of membranes. There is also this nitrazine testing. That's basically you take that same fluid and dip it in the nitrazine paper and it'll change color. It is a very sensitive test, but it's not very specific. So that is something that they will ask you on exams, is the difference, or what is the most specific or sensitive testing for premature rupture of membranes. So knowing the difference between ferning and nitrazine testing is important there. Yeah. Normal vaginal pH in pregnancy, somewhere between 3.6 to 6. The pH of amniotic fluid is 7.1 to 7.3. So you should see some changes on that nitrazine paper if it is actual amniotic fluid. All of these patients, if they're having premature rupture of membranes, should start antibiotic therapy to prevent chorioamnionitis.
And that's what that ferning looks like. And here's the nitrazine paper there. So ruptured is blue and greenish.
So another case here, 28-year-old female, approximately 23 weeks gestation, presents to the emergency department with severe low abdominal pain and vaginal bleeding. No history of trauma. Pain started approximately 1 hour prior to arrival. She has no significant past medical history. She has had an appendectomy in the past. Patient does report that she smokes tobacco. She does not have any alcohol use, but does use cocaine. No allergies, and does take her prenatal vitamin daily.
That's important.
Yeah.
Prenatals are
Definitely
important, but cocaine
those,
is bad.
Cocaine.
And so it's that severe abdominal pain, some bleeding in a pregnancy. So that's a placental abruption. That will be the test question. Yes. So that's premature separation of a normally implanted placenta from the uterine wall. Sorry about that. That mistype there form. The risk factors are high blood pressure, smoking, lots of pregnancies, cocaine use, and advanced maternal age. And they'll have painful third trimester vaginal bleeding, I think was the question there. And this is diagnosed on ultrasound, but it's good. And you can see that, not by us, definitely, but really these patients are going to be admitted OB for monitoring. And even with a mild abruption, there's some degree of fetal distress that's present, and future pregnancies are at risk for abruption as well. So really, when you're getting this patient, we're doing our emergency things, right? We're like, they're pregnant. Hopefully, like I said, once they're past 20 weeks, they're not coming to us, but it happens sometimes. And I think it's important to note, like, we're not going up there and doing like a digital exam because we don't know where the placenta is. There can be lots of things that we could get into trouble with doing that. So this is really more ruling out the emergencies and calling our friendly neighborhood OBGYN to come and help us out.
Yeah. And I think that's important to distinguish there. So that case presentation was painful vaginal bleeding for test question purposes. It doesn't always follow the rules in clinical practice, just be aware of that. But for testing purposes, the difference between painful and painless vaginal bleeding in later term pregnancies. So placenta previa is another one that can cause vaginal bleeding in a later term pregnancy. This is caused by an abnormal implantation of the placenta that ends up sliding and covering the internal cervical os. Some risk factors for this is multiparity, previous uterine surgeries, or advanced maternal age. So again, this is going to be that painless third trimester vaginal bleeding. That's typically a sentinel bleed that's followed by more significant bleeding several days to weeks later. This can be diagnosed by ultrasound because you can see that abnormal placement of the placenta overlying the cervix. Pelvic exam in these patients is contraindicated, especially in any patient with bleeding after 24 weeks. They should be evaluated with ultrasound to rule out this placenta previa before a pelvic exam is performed. These patients will then need to be followed closely by OB.
Yeah. And this is probably more than you need to know, but that's just showing different degrees of how that placenta can overlie there. So. Yeah. The accretia? Yeah. This is when the placenta implants with abnormal firmness into the uterine wall. Patient has an overly adherent placenta. Basically, it won't deliver, and then they have a lot of bleeding. First clinical manifestation is they just have this profuse, life-threatening hemorrhage with attempted manual placental separation. And, all of us do get to rotate and deliver babies, and this is like, don't tug on the umbilical cord. This is why, or one of the reasons. And then really hopefully they identify that. I don't even know. Do you identify this before? That's out of my range of expertise.
I was going to say outside. It seems like, but I think a lot of times they will know that this is based on ultrasound. They'll see it abnormally implanted. It changes the way that it looks on ultrasound, and they'll try to do this planned cesarean.
Okay. Yeah, I know some people where they didn't know beforehand, and they have a lot of bleeding, and they have that emergent hysterectomy, but kind of out of our practice. And so that's kind of more information on what that looks like there. Breathe. If I ever have to deliver a baby in the ER, it's gonna be one of my worst days. But this is when your buttocks is the presenting part, and the head is in the fundus, and the butt can't dilate the cervix as well. And so you're left with this like giant head to deliver. Could be problematic. So. Yeah, scary. I hope I don't have to do this.
Yes.
And that's kind of what that looks like. There's different positions, apparently.
Yeah. Not sure that on the ER COMAT, whether they'll ask significant questions on this, but there are different presenting types. This is more of an obstetrics COMAT question, but you do have those different ones. So frank breech is where the buttocks is the presenting. A complete breech is you'll have bilateral feet there, like it shows in the mini. middle picture, and then you've got that footling breach, which is actually where the foot will be the presenting part in the vaginal canal. So not a good day for us.
Another thing that wouldn't be a good day is if you are delivering a baby and you have a shoulder dystocia.
Yes.
So these patients, I guess the first thing to do is McRoberts maneuver to widen the pelvis. So you're placing the patient in extreme lithotomy position. So their legs are flexed and held up to the abdomen, and then someone's going to apply that suprapubic pressure. Yep. And this is when like the baby's head will come out and then go back in and come out and go back in. And I've heard it say like turtling before. And this is that McRoberts maneuver. And like I said, we're there for emergencies, and sometimes it happens. I like to make a habit of not, working in an ER where OB isn't available, because this is my nightmare. So,
but knowing on test questions, this is going to be an important differentiation, is that suprapubic pressure versus fundal pressure. If you push on the fundus, you're actually going to worsen that shoulder dystocia, so you want to make sure you're putting that suprapubic pressure down on it, because you're going to displace that shoulder under the pubic bone is the idea. So.
Okay, here's another one, fun one. You're in the ED in Guyman, Oklahoma.
Oh boy.
A 23-year-old is brought into the ER and they have abdominal pain. I'm going to guess this is a female. They describe their pain as cramping. It's everywhere, and it goes into their back. No trauma, no urinary complaints, no bleeding. They don't know when their last period was. And of course you don't have an OB on call. They're obviously gravid. It is crazy how you get patients that are like so obviously pregnant and they have no idea.
They're not pregnant.
And you can actually palpate that little baby just below the xiphoid process. In your pelvic exam, you see an umbilical cord, and that sucks, right?
Yes,
so
that
what,
sucks.
So what do you do? What are you going to do?
Panic.
Panic and run.
First thing you're going to do is you're going to...
Call it for a doctor.
Yes, exactly. No, first step in this situation is you want to identify the presenting portion of the baby, and you're going to try to actually push that back upwards into the uterus. And you're leaving it there.
Yep.
So you want to lift the head off of the presenting part of the baby off of the cord.
Yeah. So that's an umbilical cord prolapse. That usually occurs at the same time as rupture of membranes. It's diagnosed by palpating the cord on your vaginal exam. So you're going to prepare for an emergency C-section. Hopefully you will not be performing the emergency C-section, and you're going to place the patient in knee to chest in Trendelenburg. You're going to insert a sterile glove hand. Really, whatever hand finds that baby part, it doesn't, that's where you're presenting. You're not going to remove it and put on a sterile glove, like you're keeping it there. And you're just going to lift that away from the cord, and you're not releasing that pressure until that baby is delivered.
Yep.
Okay, so a patient's delivering and they suddenly become hypotensive, they're hypoxic, and they develop respiratory failure. Yeah, that sucks. Sorry, that's not good.
It's another bad day.
And it really could be a lot of things. It could be a bad PE. It could also be an amniotic fluid embolism, but really, I guess regardless, it's supportive care is the treatment. So unfortunate event, and hopefully this doesn't happen to you, but these are supportive care measures. So
purely supportive on these. Amniotic fluid embolism is a fairly common question that I've seen. Yeah. So just being aware that if you are in the middle of delivery and this presentation occurs, amniotic fluid embolism is typically what they're asking you. Preeclampsia. So this is a fairly common obstetrical thing that we need to be worried about and watching. So this is that diagnosis that requires pregnancy to be beyond 20 plus weeks. So if they're earlier than 20 weeks, they can't have the official diagnosis of preeclampsia. Your diagnosis does require hypertension. Systolic blood pressure is greater than 140. They do require you to have some proteinuria, and typically they will present with some type of edema in there. Symptoms can be wide-ranging, but typically include some type of headache, some visual changes. They'll have abdominal pain. The risk factors for this, again, extremes of maternal age, their first pregnancy, diabetes, hypertension, obesity, and either very short or very long times between pregnancies. The treatment of this, typically,
I don't even know that they say bed rest anymore.
I don't think they do.
I don't think it does anything.
I think the big thing there is going to be blood pressure.
Call your OBGYN.
Blood pressure control, and then definitive treatment for this is going to be delivery. That's the only real treatment we have for that. But consultation with obstetrics is going to be your big one there. They are at increased risk of preeclampsia in future pregnancies. And to note, this 6 weeks after delivery, you're still at risk for preeclampsia. So if a lady who just delivered 2 weeks ago comes in with elevated blood pressure and edema, you need to be considering preeclampsia as a differential.
All right, another one. You have a 20-year-old G2P1 female. They don't have any medical problems that they know of. They're coming by EMS for a headache. So she's 36 weeks pregnant. This is an uncomplicated pregnancy to this point. The blood pressure is 155/60. Pulse is 76. Temperature is 98. Pulse ox is 99% on room air. Your respiratory rate is 17. Their glucose is 120. They report intermittent bright flashing lights in their vision. They have a severe headache. It's constant. It's worse with movement. And their headache started yesterday and it's getting worse. Bedside ultrasound does show an IUP with fetal heart tones at 155. Your fundus is palpable to just below the xiphoid. This is a really long question. After evaluation, patient starts having a seizure. What are you going to do, John?
Again, I'm going to curse my luck.
For sure. It's a bad day.
Then I'm going to start a large amount of magnesium.
Yeah.
So I'm going to give the 4 to 6 grams of magnesium IV.
Yeah.
And then these patients, they require a lot of mag to stop their seizures and to keep them from having repeat seizures.
Yeah.
So in order to do that, you're going to be monitoring them for signs of hypermagnesemia.
And
while you're doing this.
What is that?
So decreased reflexes
So-
and respiratory depression.
So
are the
too
two
much
big ones.
magnesium can cause that. That's going to be a test question, I think. Would it be the decreased reflexes?
Yeah.
Or the... And really, how are you going to treat that if you do have hypermagnesium?
I'm going to give them some calcium.
Okay. So good point. Most of the time when we have a patient with seizures, you're going to give a benzodiazepine.
Right.
But this is a patient that is pregnant with preeclampsia, and now it's eclampsia because they're seizing. So that's the difference in those diagnoses is you have a patient with high blood pressure, they're pregnant, blah, 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 headaches, flashing lights, all of those things. That's preeclampsia until they start having a seizure. That's when it becomes eclampsia. We treat with magnesium, but the treatment for this patient... the cure, I guess, would be actually delivery of the fetus, of the baby. So you're going to do the magnesium and you're going to call for help to deliver the baby. If you're in your own shop, good luck.
Yes.
So
Emergent
sick patients,
transfer.
super sick.
So HELP syndrome. This is a variant of eclampsia. So once you get to eclampsia, that's going to be your preeclamptic symptoms plus that seizure. HELP syndrome is very specific. This is going to be those patients who have evidence of hemolysis. They will have those elevated liver enzymes and low platelets. This is one of those times where the name of the syndrome actually helps you remember it. Yeah. So it's hemolysis, elevated liver enzymes, and low platelets. So
no coag abnormalities. That might be a question. Your PT-INR, PTT are normal. All right. And this actually does apply to us, unfortunately, but that peripardium cardiomyopathy, this is a 3rd trimester pregnancy. Patients, they can come in with dyspnea, lower extremity edema, which they all just kind of have that at that point, in orthopnea, whether they are in their last month of pregnancy or if this is up to 5 months postpartum, actually, you want to consider this as a diagnosis. Risk factors are advanced maternal age, pregnancy with multiple fetuses, history of preeclampsia, and maternal cocaine abuse. Sad.
Cocaine.
Yeah, nothing good came from cocaine, I don't think. And then so it's really just the same treatment as you would for other types of heart failure, and your future pregnancies actually put mother at a very high risk of death. Yeah. When I did my OB rotation, we had a patient that had twin pregnancies that developed like severe cardiomyopathy, and like they had, after the baby was born, reduced ejection fraction, and they're like, don't ever get pregnant again, you will probably die. So scary stuff.
Postpartum hemorrhage. Most common cause of this is going to be uterine atony. That's going to be almost guaranteed to be a test question. They like to test these things in the emergency literature. So again, it's going to be that uterine atony. You treat that with supportive care, fundal massage, and then Pitocin or oxytocin infusions there. Typically, you'll do that in consultation with your obstetricians again there, but you want to make sure that you recognize that and you start doing that fundal massage. Second most common cause, again, that's going to be retained products, particularly the placenta. So consider that in delayed hemorrhage. Somebody who doesn't have a lot of immediate post-delivery, postpartum hemorrhaging, but then all of a sudden has a large amount, and you want to consider that retained products. That's going to be taken care of by OB. Uterine rupture. This can occur in patients who are doing vaginal deliveries after C-section. It can occur in other situations. that in those patients you'll see them basically all of a sudden they'll have a loss of tone of the uterus, and then there'll be kind of a flattening out of the fundal area there, and then you'll feel like a baby floating around in there, and the patient immediately looks very shocky and very bad. So that's a patient you'll want to consider uterine rupture on. And then there's this uterine inversion, and this is what was the like panic mode when you're a medical student trying to do the placental delivery on your OB rotation, and they say, hey, don't pull on the umbilical cord, and you're just sitting there thinking, please don't let me be the one that pulls the uterus out. That's what you want to do. It's caused by that excessive traction on the umbilical cord. And the treatment of that is either manual reduction or emergent laparotomy. So
endometritis, this is fever, abdominal pain, and uterine tenderness with that malodorous lochia. This is polymicrobial infection. The most number one risk factor for this is actually after a C-section. Other risk factors would be if they have prolonged rupture of membranes, or if you have multiple vaginal exams while they're in labor and you're going to give them antibiotics, and we're calling OBGYN. So
one of the other things we see, mastitis, it's fairly common. Most women will get this at some point during breastfeeding or at some point. This is just an inflammation or infection of one of the ducts in the breast while breastfeeding, most commonly caused by Staph aureus. The treatment is dicloxacillin.
Never given it.
Never given dicloxacillin, so typically we will give Keflex or cephalexin in the emergency department, but dicloxacillin is the test answer.
And it's important to tell mom to keep breastfeeding on that side. So.
Yes.
Ovarian hyperstimulation syndrome. So this is, when you consider women taking fertility drugs. Most of the time these cases are mild, but the severe forms, they can have abdominal distension and ascites. They're not making urine. They get a pleural effusion, and they can be in respiratory distress. When you see elevated hematocrit, that's the most important measure in deciding if the patient should be hospitalized. I think if I see this patient, it's not going to be up to me whether I hospitalize them. Right. I think they're staying until proven otherwise, and I'm going to call the experts. And it says here if their hematocrit is greater than 60% and they have ascites. But you can also see that elevated liver enzymes or coagulopathy, and it's just supportive treatment. I've never seen it. Never
seen it. It's in the literature a lot more. This is also those patients that you don't do adnexal exams on because you can cause shock and worsening conditions. So this is one of those. If you have a concern for this, it's rapid consultation with the OB experts on this.
And the end of these are just kind of random points here, but gynecological cancer. So if you have a patient that comes in and they've already been through menopause and they start bleeding, this is cancer until proven otherwise. Right. And this is kind of out of our hands, but it's really more follow-up, like, hey, if we rule out the emergencies, they're not anemic, this is a super important that they follow up for an ultrasound, and they'll get endometrial biopsies, and this is that OBGYN follow-up. There's a lot of risk factors for this: the diabetes, obesity, nulliparity, early menses, and late menopause. If the older patient has malignant pleural effusion or ascites, you can consider ruling out ovarian cancers. And I think these are hard to diagnose and often, unfortunately, found pretty late. Emergency contraception. I don't know what you would need to know on this. Maybe you'll identify the drugs, but Plan B is over the counter, and then that Ella is something that requires a prescription. Someone may be coming to you asking for that prescription, and I think that's more of an ethical discussion not for us. And so that's kind of in your practice or your clinic's practice, but they can get that Plan B over the counter if you're someone that says, I don't prescribe this.
Right.
So
I was going to say, I don't know that there will be too many questions at your level about this.
Probably
but
not.
It's good to know that they're out there and where you can kind of guide your patients for.
Right. So. And here's the resources. That was really long, and I hope it was useful. Please give us feedback if you actually listened, if it was useful or if there were things that we could make to make it better. So,
thank you, everyone.